Within, I mentioned the umbrella of dementia, the most common and the one that we typically think about is Alzheimer's disease. Alzheimer's disease, you should look in your vignette for your person to be about 70, I would say, to 90 years old. The average sort of age I mentioned here, it typically takes about 8 to 10 years for someone to be from diagnosis to death for Alzheimer's. So it's a relatively slow disorder. The predominant symptom, the predominant cognitive domain that's affected is memory. And I think we all know that. You can later have abnormalities in visual spatial abilities and behavior, right? I think many of us who've rotated in the hospital have seen sort of behavioral disturbances in patients who have relatively end-stage Alzheimer's disease. As before, age is the most important risk factor, but there are genetic things that we should think about. So many of you will hear or write about the ApoE4 gene. The more copies of that you have, the more likely you are to have dementia, but it is not going to cause dementia in everyone, right? So if I have someone who has no ApoE4 copies versus someone who has one copy, the person who has one copy is about 3 times more likely than baseline to have dementia. A person who has 2 copies is about 15 times more likely than baseline to have dementia, but it itself is not pathologic. These other disorders, however, right, so these genes that I'll list, APP, presenilin 1 and presenilin 2, typically dispose people to early onset familial Alzheimer's, right? Diagnosis in 50s and 60s, sort of multiple family members with early onset. And I would think of that more of like a genetic inheritance pattern. Unfortunately, there are no disease-modifying treatments for dementia. There's recently been some controversy about the FDA approval. That's not the topic of today's talk. There are still no efficacious disease-modifying treatments for Alzheimer's disease. You can slow the decline, typically, right, by only a few months with cholinesterase inhibitors, and there are 3, and I will give people an opportunity in the chat to name some of them. Donepezil, awesome. It's sort of the most commonly prescribed one. And then the other 2 are so hard to remember, and you're like, people always use donepezil anyway. Galantamine, awesome. I have never used pezolizumab, but maybe it is. Rivastigmine, absolutely. Yeah, donepezil, rivastigmine, and galantamine are sort of the 3 that I would expect to see on tests. You can also use memantine, which is an NMDA receptor antagonist. My next question that I have at the bottom of the slide is, which chromosomal abnormality is associated with a significant increase in Alzheimer's disease? Some data would suggest 80% of people who have this. Yeah, Downs, right? So that APP gene is carried on chromosome 21, and so it's the amyloid precursor protein. And so we'll get into the pathology of Alzheimer's, but one of the pathologic features is amyloid plaques. And so people who do not have Downs have 2 copies of the APP gene, have 2 copies normally of that amount of amyloid. People who live with Down syndrome have that 3rd chromosome 21, that extra dose of amyloid. It's near 80% of people with Down syndrome who live to 50 years old. By some studies say 60%, will eventually develop Alzheimer's disease.